Okay, we're going to go ahead and get started. Welcome, everybody, to the Brain 101. This is the fifth of our six sessions in our mini medical school presentation. So thank you all for attending another night. We've got a very, very exciting program tonight that we're going to hear. I'd like to introduce myself again. I'm Kevin Lillihide, chair of the Department of Neurosurgery. And I will be hosting this along with Tammy Lack, who you're seeing in the picture there. Tammy is head of strategic development for the Department of Neurosurgery. She's also executive director of the Neuroscience Innovation Initiative, and we'll talk a little bit about that. So this session is sponsored by the University of Colorado, the Anschutz Medical Campus, but it's also sponsored by the Neuroscience Innovation Initiative. Again, this is really the NII is a precursor to developing a comprehensive neuroscience institute on here at the University of Colorado, and its mission is to help integrate our neuroscience activities on the campus here at Anschutz, but also across the state. We're creating a platform for collaboration between neuroscientists, and also to communicate, the wonderful work that's being done in the neurosciences, not only at the University of Colorado, but at our universities all across the state of Colorado. So our goal, obviously, is to make Colorado the healthiest brain state in the country. So the program consists of 7 different programs right now, and what we're going to hear from, if you look on the left-hand side of the slide at the near the bottom, we're going to hear from our members of the Neurocircuitry program in the talk tonight. So here again is our 5 of 6 sessions. The title is going to be Introduction to Movement Disorder and Neuroengineering. Our speakers are going to be Dr. Cristin Welle, Dr. Daniel Kramer, and Dr. Alex Baumgartner. And before introducing them formally, making a couple of announcements. One, there's still time to make a reservation for our graduation ceremony, our graduation breakfast. Each week after these sessions, Tammy sends out an email that has not only the recordings, but also has the answers to questions that we don't get to during the hour. And that's got Tammy's email on it, so you can respond to her if you're interested in attending our graduation. During the talks tonight, one of the real important things is the chat function. And down at the bottom of your screen, you see the chat. And at any time during the talks, please put in a question. And Tammy's going to keep track of those. And then we're going to get to as many of the questions as we can at the end of the hour. If we don't get to them, we will send you answers. We send the whole group an email with answers to those questions. So with that, I'm going to introduce our topic tonight and our speakers. I'm going to introduce, this is Introduction to Movement Disorders and Neuroengineering. Our first speaker is going to be Dr. Alex Baumgartner. Dr. Baumgartner is Assistant Professor of Neurology here at the university. He attended medical school at Brown University, did his internship and initial residency at Beth Israel Deaconess Medical Center, and then his chief residency at Harvard Medical School. He did his fellowship in movement disorder here on the CU campus. His research is in oscillatory beta dynamics that inform biomarker-driven treatment optimization for Parkinson's disease, and the effects of brain stimulation on quantitative sleep, EEG, during non-rapid eye movements in Parkinson's disease. So I don't think we're going to hear all about that, but that might be a level above all of us. So our second speaker is Dan Kramer. Dan is an assistant professor of neurosurgery and director of the Brain-Computer Interface Laboratory. Dan went to medical school at the University of Pennsylvania, did his internship and residency at the University of Southern California, and then he did his fellowship at Stanford University, really in the BCI, the Brain-Computer Interface program. His clinical interests are in movement disorders, epilepsy, facial pain, and he's skilled in multiple different procedures in neurosurgery, which include laser therapy, responsive neural stimulators, MRI guided focused ultrasound, and then new applications for brain stimulation and also interested in microvascular decompression for trigeminal neuralgia. His research, he spent a dedicated research year under an NIH grant at Caltech, working in the brain-computer interface laboratory. We're going to see a little bit about that, I think, in his talk, where the human brain interfaces directly with machines to restore motor and sensory function to paralyzed individuals. And then he went on to continue this work at Stanford and then has brought that work here to the University of Colorado. And our last speaker is going to be Dr. Cristin Welle. Dr. Welle, previously associate professor, as of today, is a full professor in the Department of Neurosurgery and Physiology and Biophysics. She's vice chair of research for the Department of Neurosurgery and leader of the bioelectrics laboratory here at the university. She attended graduate school at the University of Pennsylvania, and then from there went to work for the FDA, where she started the neural interface program at the FDA. We were lucky enough to recruit her here to the University of Colorado from the FDA. Her bioelectrics laboratory investigates how neurological medical devices interact with the nervous system. She investigates circuit-level structures and functional implications of neuromodulatory and brain-computer interface devices, and she uses optogenetics, chronic EEG, and longitudinal in vivo imaging in animal models in her research. She has been a kind of a leader in the use of vagal nerve stimulation, and her colleagues and her have shown that it activates the cholinergic system, which is important for learning and plasticity. In addition, they have demonstrated that the use of a VNS stimulator improves learning and complex motor behavior. Recently, I think a lot of you, about 2 months ago, Elon Musk announced work that he's done between brain-computer interface and his Neuralinks. And the person that CNN went to get a comment about this was Dr. Welle. So she's got a great interview from about 6 weeks ago, 2 months ago on CNN. So with that, I'm going to turn it over to Dr. Baumgartner. Let me stop my share. There we go.
There we go. Thanks. Sorry, I was not allowed to unmute myself there. So hopefully you all can hear me now. Please let me know if not. But thanks very much, Dr. Lillihei, for the kind introduction. And I'm going to spend a few minutes talking about an overview of movement disorders, a branch of neurology and neurosurgery that tonight's talks will focus on. So hopefully I can give you a little bit of an overview into the practice of movement disorders, how we think about these disorders, what they are, and how we manage them in the clinic and in the operating room and beyond. So first, a definition. What are movement disorders? We can use this definition, which says that movement disorders are neurologic syndromes where there's either an excess of movement or a paucity of voluntary and automatic movements that's unrelated to other neurologic symptoms like weakness or spasticity. And so that gives you a little bit of a clue into how we start to think about and organize these disorders. The very first step into what's called the hypokinetic disorders or hypokinesias, and then into the hyperkinetic disorders or hyperkinesias, with those referring to specifically a paucity or absence of movement, and then an excess of movement on the other side. The hypokinetic disorders, far and away the most common one that we see is the disorder known as Parkinsonism, which has a few defining features, including akinesia, or an absence of voluntary movement, or bradykinesia, which means a slowness of voluntary movement. But there are others as well. Again, Parkinsonism being far and away the most common of the hypokinetic movement disorders. There's also a broad range of hyperkinetic movement disorders. These disorders are all characterized to some degree by an excess of movement or too much movement that is involuntary or sometimes semi-voluntary or somewhat under the control of the patient experiencing them. And so that also gives you a little bit of a clue into how a neurologist in the clinic might think about diagnosing and managing these conditions, which is somewhat different than other branches of neurology, where the focus is on identifying where along the nervous system a problem lies, either in the brain, the spinal cord, the cerebellum, the peripheral nerves, or muscles that are innervated by those peripheral nerves. Instead, in movement disorders, the practice really is to attempt to define the type of movement disorder, which that in combination with other factors like the patient's age, the rapidity of the onset, the course of the movement disorder, whether it's intermittent or constant, and other factors will help clue you into a potential cause. But all the movement disorders that I've listed here are really symptoms. These are descriptions of things that people are experiencing. None of them are a diagnosis or a specific disease entity in and of themselves, but defining the type of movement, or what we call the phenomenology of the movement, is a first step into diagnosing the specific condition causing the movement disorder. The other unifying factor for most of the movement disorders that we will talk about is some connection, at least, to what's called the basal ganglia. These are groups of nuclei or gray matter in the deeper down or basal parts of the brain, beneath the surface of the brain, that are highly interconnected, both functionally and anatomically. Most of the basal ganglia, or the most common ones that you hear people talk about, are nuclei that include the caudate nucleus, the globus pallidus, the putamen subthalamic nucleus, and substantia nigra. There are a few other structures as well. But you can see here from this figure on the left that these are anatomically very closely related, and they're also functionally very closely related. So I'll show you in this next slide here. There are always ongoing efforts to define or create schematics that describe the function and the interconnectedness of the basal ganglia. And suffice it to say, this is a very complex region of very highly interconnected networks that involve communication between structures such as the cerebral cortex or the surface of the brain, different nodes within the basal ganglia, and then other structures outside of the basal ganglia, including in the brainstem and cerebellum. And as with any schematic, this is probably an oversimplified view, but it highlights at least some of the complexity of the way that this system operates. And it's always outdated, as with any other type of description of something like this. You know, as soon as you make a schematic like this, it's outdated because there's been some new discovery, some new connection that is not accounted for in this type of schematic. But perhaps a bit more simply, we can describe it this way: with the most important pathways or connections in the basal ganglia involving what's called a direct pathway and then an indirect and a hyperdirect pathway, with the basic mechanism of the system being what's called a center surround mechanism, where the center, or what's called the direct pathway, is responsible for facilitating movement or encouraging movement that the cortex or the rest of the brain is trying to originate. And then the other systems, the indirect and the hyperdirect pathways, trying to filter out and deselect movements that are unwanted. And so even more simply, we might be able to say that this interconnected network between the motor cortex or the surface of the brain, the basal ganglia, and also the cerebellum is responsible for choosing what movements to do, and then also deselecting or not choosing movements that you don't want to do. And so in that sense, the basal ganglia are particularly responsible for refining and selecting movements to make them accurate and as selected as possible. So with that in mind, I want to show you just a little bit of some classic examples of movement disorders that we see in the clinic. One of the most common types of movement disorders we see is called Parkinsonism. This would be a little bit different than Parkinson's disease. which I'll talk about in just a few minutes. The Parkinsonism refers to a constellation of symptoms, the cardinal feature of which is that bradykinesia or akinesia, again, being a slowness of movement or a lack of movement, that has a few particular characteristics. One, that it has a sequence effect, meaning that the longer a movement goes on, it becomes slower in speed and smaller in amplitude. There are a few other defining features. There's a notable difference between internally triggered or internally cued movements and externally triggered movements. So something that someone does voluntarily versus a reflexive movement, like trying to catch a ball or an object that's thrown at them. There's also rigidity or an increase in the resistance of the muscles to passive stretch or manipulation. Many people with Parkinsonism also have some tremor. That tremor typically occurs at rest, meaning that it occurs when the hands are rested, fully supported and not moving. Other features of Parkinsonism include a loss of postural reflexes or the automatic involuntary actions that keep you upright, especially when something challenges your balance, an obstacle in the road or someone bumping into you on the sidewalk, something like that. People with Parkinsonism often have changes in their posture. Typically, they're stooped over or hunched, they're not standing up straight. And the freezing or blocking phenomenon is also characteristic. We'll see that in the next slide as well. So here's a patient with very typical Parkinsonism features. You can see she has a tremor of several body parts, including the left arm and leg, but also the face and chin. These movements get progressively slower and smaller the longer that she repeats them. She doesn't swing her arms much when she walks. And you can see that that tremor continues, particularly in the left hand when she walks. This is a patient who experiences freezing. Freezing, specifically when it refers to gait, is an inability to move the legs forward to continue with walking or locomotion despite an attempt to do so. And as this patient tries to get his legs to step to make this turn, you can see he's really unable to do so, or unable to do so without significant help. This freezing phenomena is typically worse in certain situations, like when making a turn, going through a doorway or another tight space, in other crowded areas. And that's highlighted here was this gentleman struggles to get his feet to continue moving as he tries to go through the doorway. Tremor is another commonly encountered movement disorder in the clinic, perhaps the most commonly encountered movement disorder. By definition, tremor is a rhythmic and oscillatory movement produced by alternating contractions of agonist and antagonist muscles. One of the most common forms of tremor is called essential tremor, a condition that causes tremor that primarily affects the arms or upper limbs, but also commonly affects other body parts like the face and neck, the voice, and sometimes the trunk and legs as well. You can see the shaking that this gentleman has in both of his hands, mostly in his fingers. There's a bit of shaking in his head as well. Like the tremor of Parkinson's disease, which most commonly occurs when the hands are resting or sitting in the lap. In essential tremor, we see the most noticeable tremor usually when the hands are moving or doing something. So for writing, as you see here, or drawing, but also for drinking, eating, doing buttons and zippers, those types of things. Dystonia is another commonly encountered movement disorder. This is a movement disorder that's characterized by sustained or intermittent muscle contractions, which cause abnormal, often repetitive movements or postures. These movements or postures are often patterned or follow the same type of movements, if you watch them long enough, there is often some tremor that can come with or is associated with dystonia. And one of the more common forms of dystonia that we see in the clinic is called cervical dystonia, or dystonia that affects the neck musculature and leads the neck and head to be held in an abnormal way. This gentleman has a fairly obvious abnormal position of his neck. Although he can move it in different directions, the general trend or tendency is for his neck to be turned, like you see, towards his right ear, and then also tilted down such that his left ear is closer to his shoulder. It's not uncommon for people to have some degree of shaking in their head or neck when they do this, when they have this condition as well. Becomes much more apparent again when he walks. So those are at least a few of the most common movement disorders that we see in the clinic. Again, there are a whole host of other disorders that we won't have time to discuss, but hopefully it gives you a sense of what we're trying to think about or look at when we see patients in the clinic with movement disorders. I want to touch just briefly on Parkinson's disease in particular. Again, one of the more common movement disorders that we encounter in the clinic that's characterized by those symptoms of Parkinsonism, namely bradykinesia, rigidity, tremor, absence of postural reflexes, and changes in posture. Parkinson's disease is, at its core, characterized by a loss of certain neurons in a part of the brain called the substantia nigra, or black substance, which normally, as you can see in this upper slice through what's called the midbrain, is a very dark pigmented appearance. But as those neurons die off, that pigmented appearance is lost, which represents the dying off of dopaminergic, or neurons that produce dopamine in that part of the brain. And because these neurons have vast connections throughout the rest of the brain, there is a whole host of neurologic symptoms that is associated with the loss of those neurons, as well as other neurons besides dopamine-producing neurons. But the hallmark feature is the loss of these dopaminergic neurons in what's called the nigrostriatal pathway, or a pathway connecting the substantia nigra to the striatum or other networks within the basal ganglia. What's going on in these neurons that causes them to die off? Well, the characteristic feature of seen in these neurons is called a Lewy body, this circular object seen in the right panel there that's composed of a few different things, but namely a protein called alpha-synuclein. And so the thought is that, at least at its core, the nature of Parkinson's disease and the pathologic underpinnings are that this protein called alpha-synuclein, which is present normally in the brain, begins for some reason to misfold. And when it misfolds, it can clump together or form oligomers. And these oligomers grow and grow until they form larger groups of this misfolded protein that eventually become toxic to the neuron and cause the neuron to die off. And so with that in mind, I won't go into the treatment of Parkinson's in a whole lot of depth, but I'll suffice it to say that the root of the treatment of Parkinson's is based in replacing what's being lost, namely dopamine. And so you can see here a whole host of medications that are available to treat symptoms of Parkinson's, most of which resolve around replacing dopamine or adding dopamine back into the body, or prolonging the effect or prolonging the therapeutic ability of the dopamine naturally occurring in the body, or the dopamine is being supplemented with medications. However, Parkinson's is a progressive neurodegenerative disease, meaning that those dopaminergic neurons originating in the midbrain continue to die off. And as that happens, people will experience progressive symptoms. One of the most problematic of which is what's called motor fluctuations, meaning that it becomes increasingly difficult to adequately treat their symptoms with medications. And people experience poorly controlled symptoms, both when medications are at a too high of a level within the body that leads to abnormal involuntary movements we call dyskinesia, but they also have poorly controlled symptoms when the medications wear off and at their lowest levels in the bodies. And that window between too much and too little becomes thinner and thinner as the disease progresses and as those neurons die off. And that's the time when we start to think about other surgical treatments for Parkinson's, the most well-known of which is deep brain stimulation. I'm going to end there so that Dr. Kramer can pick up and talk about deep brain stimulation for Parkinson's and movement disorders. But I'll say thank you very much for your time and attention.
Great. Thank you, Dr. Baumgartner. Just for all the attendees, our final exam at graduation is going to have his diagrams. You'll have to recreate. So, very impressive.
Should I wait for questions or?
Oh, no, go ahead. We'll do the questions at the end.
Got it. Okay, perfect. Let me get this up then. All right, so as mentioned, I'm Dr. Dan Kramer, and I am a neurosurgeon here. And I work in a number of different disease domains, but movement disorders is one of them. And I'll talk about one of the main surgical treatments for movement disorders. Although this can be applied, deep brain stimulation is starting to be used, well, it has been for a long time, but starting to pick up steam in a number of different areas and has been recently approved for a couple of other indications such as epilepsy and obsessive compulsive disorder. And there's definitely more than a few in line for hopeful approval. That's not advancing. Let's try that. Here we go. Nothing to disclose here. So deep brain stimulation is kind of right in the name there, which is that it is stimulating deep into the brain. And where we're targeting, as Dr. Baumgartner was pointing out, is some of these areas that are involved in the basal ganglia and related structures. And I have a less complicated, but still very complicated version of this diagram. And then what it shows is that there's a circuit, really. And as in diseases like Parkinson's, as you start to lose some of the input from one of the areas, that increase, those inputs are excitatory or they're inhibitory, meaning they, increase the activity in the next region or decrease it. And so as you start to lose that, the system gets out of whack. And so when it was helping you move before when you wanted to move and keeping you from moving when you didn't want to move, that's now out of whack. And in something like Parkinson's disease, you end up with these symptoms like bradykinesia. We have these slow movements. And so the idea with deep brain stimulation is we target one of those regions and restore that balance. And the electrical stimulation itself is very complicated. There are lots of debates about what it's actually doing, but you can sort of simply think of it as it's kind of shutting down one of the overactive regions. And that's essentially how we plan our targeting with that. And so this method was approved by the FDA back in 2002 for Parkinson's disease and essential tremor actually a little bit before that. And those are the two indications for a long time. And like I said, some more increasing indications, but I'm just sort of going to focus on its role on Parkinson's disease. And so it's very effective at reducing the three cardinal symptoms of Parkinson's disease. With tremor at about 75% improvement, rigidity or these stiff movements is 71%, and then there's about 50% of this akinesia or slow movement. And more impressively, perhaps, is that it works in about 97% of patients. So even if you don't get quite that much improvement, you typically will see at least some. And similar for essential tremor, it's extremely effective. And it has, we'll talk about this in a second, but few side effects. The big downside, of course, is that it is a brain surgery in order to do it. And in addition, helping with these motor symptoms, there's a couple other benefits that come from this deep brain stimulation. So there's a number of reasons that we sort of decide that a patient has moved from medications into being a good candidate for surgery. The first is worsening motor symptoms despite best available medical therapy. So if those cardinal symptoms are starting to get worse, and the medications are not as effective, that is a time to consider deep brain stimulation. But even if the medications are working, but you have significant side effects or that dyskinesia, which is this writhing movements, and that's from the too much medication, that you can reduce that with the surgery. Dr. Baumgartner also was mentioning these sort of on and off times that happen as that therapeutic window shortens. And so this is sort of, there's a graphical depiction here of it getting into this dyskinesia and this, and then having these troubling off times where sort of, the medications almost fall off a cliff where suddenly, you're not due for your next medication dose, but your symptoms have come back pretty severely. And deep brain stimulation really smooths that and keeps that therapeutic window nice and wide for a long period of time. And then the final good indication in Parkinson's disease for deep brain stimulation is tremor, which is not always affected by the medications. And some people have a tremor dominance to their Parkinson's disease. And deep brain stimulation almost always works for tremor. So those are good reasons to get it. Not great reasons are for non-motor symptoms. So Parkinson's disease, this loss of the dopaminergic cells, causes lots of different things. The main ones are motor, but there are plenty of non-motor symptoms such as constipation or sleep disturbances, something called orthostatic hypotension, which means your blood pressure drops quickly when you stand up. And it does not work particularly well for that. And that's partly because we're not really treating the disease itself. We're just treating some of the symptoms of the disease, and the area that we've sort of figured out works well are very involved in the motor components of this. Now, it is a brain surgery, but it is relatively safe. Infection's about 2 to 5%, which is the most common thing. And symptomatic hemorrhage, meaning a bleeding causing, persistent symptoms, that's less than 1%. So as much as it is a surgery, it is a relatively safe thing for people who their medications are no longer effective. So how do we do this surgery? Well, there are a lot of different ways to do it. They all consist of the same basic components, but there are many, many different methods. And at our meetings, we love to get into heated, nerdy debates about them, but they all work very, very well. And in fact, have gone head to head, and there's not really any superiority to any of the ways that these are done, which is great. Essentially, on the day of surgery, one of the first divisions in the way people do this is either awake versus asleep. This is one of the few surgeries in neurosurgery where we consistently do an awake surgery, meaning you are awake for parts of it while we're doing this, which I'll talk about in a second as to why we would do that. One thing to be aware of is if you are awake, we stop medications, which can be sometimes a challenge for patients, of course, because that means they're in sort of their worst state. And then we place fiducials. Fiducials can mean a lot of different things, but essentially it equates to something will be screwed into the skull. And what we're trying to do in that scenario is try to map your brain onto the MRI space of your brain. And so we've created these targets, we've mapped it, we know exactly where we want to go. And we've done that on the MRI, and now we need to get that into the real space of where your actual brain is. And we can do this with a high degree of accuracy, hence the term fiducials. That's sort of a term to mean that we have an honesty in the real space to the imagined space of the MRI. And we can do that with essentially sub-millimeter accuracy. So we can get kind of within 1 millimeter of the structures that we want. And that's how we can make very tiny holes and pass these electrodes in. And so that is what we do. We make some small incisions, drill about nickel-sized holes into the skull, and then pass these small electrodes down. And we go into these known locations, and this is where, in Parkinson's disease, we pick these areas of the basal ganglia, but we pick different areas for these other diseases. And this is another branch point as to how people do this, but about half of us will do microelectrode recordings, where essentially we're listening to the brain, and we can hear the way the brain responds, and that tells us we're in one structure versus another structure. And these have been kind of worked out over the decades as to, sort of what firing rate patterns, of the neurons will tell us, oh, okay, now we're in this, area, and then we pass through that, and then we're going into the next area, and it gives us a very high degree of accuracy. Now, not everyone does it anymore. We worked that out back when we did not have MRIs at all or good MRIs. And so some people don't feel that that's necessary anymore because the MRIs are so accurate. And there are sort of pros and cons to doing it each way. I do this with recordings because it's sort of a belt and suspenders. The microelectrode recordings are true, and so they can really tell us exactly what structures we're in without having to worry about the brain having shifted a little bit or something like that. Then once we're done, we get the electrodes all locked into place. We place a generator, which is a fancy name for a battery, and that all stays underneath the skin. And then we program that usually a few weeks or a month later after the brain is kind of calmed down from the surgery itself. But otherwise, it's pretty well tolerated. And then, this is where I pass off to Dr. Baumgartner, and he starts doing the programming, and that's where kind of the real benefits begin. Recovery is pretty well tolerated. It's usually minimal pain, and people are kind of back to normal within 2 weeks or nearly back to normal. And there's minimal restrictions. Sometimes people worry about, can they fly or, get back to their activities that they like to do. And that's kind of the whole idea, is get you back to all the things that you love. And so we do that once we make sure all the wounds are healing and things like that. And you can even get things like MRIs in the newer systems. They are MRI compatible. In total, there's usually, not everyone does it exactly the same, but usually 4 incisions, 2 on the head where we implant the electrodes, 1 in the back of the head where we attach the connectors, and then 1 on the chest where we place the battery. So they're usually pretty well hidden, and the hair goes back. So overall, it's a well-tolerated and very effective surgery for Parkinson's disease, for the other movement disorders that we treat, and for some of these other indications. It works quite well with a relatively safe surgery. So I'm going to, since this is partly on the neural engineering side, I'm going to move into my other hat, which is research. I'm sort of a clinician, but take these opportunities where we are doing recordings and doing other surgeries with the human brain to get at some of the underlying ways that these things work. These are very, very rare opportunities. There's lots of great neuroscience research, but it is not easy to get access to the human brain. And so most of that research is done externally with scalp EEGs or fMRIs or things like that, where we don't have to do any surgery. But since I'm already doing the surgery, we can either do different tasks or different activities to try to learn about the brain. And sometimes we just add, a few minutes to the surgery and ask people to participate while they're doing it, which are usually happy to do. And then we can learn really valuable pieces of information. So there's sort of 2 main parts to my research. And the first is to really understand how these areas of the basal ganglia and related areas, how they really functionally work. So you saw this complicated diagram with these pluses and minuses. And the goal of my research is to kind of get past the pluses and minuses of, inhibit here, excite here, but really to understand functionally, what is the point of this region? What is it trying to do that it then passes off an increase or decrease of signal? And so that's kind of our goal. So while we're recording from these different areas already for the surgery, we have people engage in a task. We have these cameras that are above it, so we can track in sort of that middle picture up at the top right here. I'm not sure if my mouse can be seen, but right here, we can actually track the fingertip or really anything we want, and we can reconstruct that so that we can get these really nice 3D models. And then you can see we're sort of tracking the different activity of the neurons through space, and we're learning things, really valuable things about how these areas respond to different movements, which helps us to understand why it is that these areas, 1, go wrong in these different movement disorders, and 2, why we can use deep brain stimulation or other techniques to help improve those symptoms. So that's one area. And then the other area, as mentioned, is brain-computer interface that I work in. And this is another opportunity to record from the brain, but this one is pure research only. So it's quite an undertaking, particularly for these patients. But we engage patients with spinal cord injury or ALS, where the brain component is working just fine, but they've lost connection with the rest of their spinal cord. So we actually will implant these small electrodes called Utah rays. There are different kinds of electrodes, which I'll talk about in a second, but the mainstay is these Utah rays, which are tiny here, as you can see, and we implant them into the cerebral cortex in specific areas that work for motor or sensory. And then we can both record brain signals and also stimulate back into the brain and try to restore some of that loss of motor sensory. So here's one of our first patients for my group here, where we work in conjunction with one of my old labs, Caltech and USC. And here's a cervical spinal cord injury patient, and he's controlling this robotic arm with just the thoughts from his brain. So he has lost control of his arms and legs, and he's able to control this robotic arm. And this is him. This is the first thing he wanted to do, which was to drink a beer on his own. So that's him drinking a beer with his first use of the robotic arm. And there's setting it back down. So this is been going on for quite some time now, almost better part of 15 years, but has gained a lot of press recently because of some of the higher level tech firms, such as Elon Musk, but also Facebook and some of the others had gotten pretty interested in this, which is and this technology really sort of offers a great opportunity to help these patients and also to learn really valuable things about the brain so that we can help these patients, but also future patients. And which is also a big area of my research, which is not just to study the direct motor sensory, but also how the brain performs some of the most key functions for thinking, which is executive function. And this is executive function is a fancy name for kind of the way you do future planning and problem solving and things like that. And it's obviously very devastating when that is lost, which is one of the things also lost in Parkinson's disease, but also lots of things, Alzheimer's disease and traumatic brain injury, to name a few. And so we're making use of these Utah rays, but also a new electrode, a fancy new electrode called a neuropixel, which is thinner than a human hair and can record from hundreds of neurons at the same time. And we're using that to study and really understand how the brain executes these really complex and things about the world, and is essentially infinitely flexible, which means that it can solve just about any problem, as we do on a daily basis without really trying very hard, but also complex problems where we do try really hard. These are features that really make us human and set us apart from the other animals, and are very difficult to study in sort of the traditional ways, using things like fMRI, just because it's so complicated and so flexible that it's really difficult to get that with kind of these big, big sweeping recording devices such as fMRI or scalp EEG. So we're making use of these tiny devices to try to get at the underlying function in these neural populations. So, all right, with that, I will stop and pass this over to Dr. Welle, who also works on some very, very cool stuff, and her and I work together on some of these things and have some cool projects related to this coming down the line.
That's right. Yeah. So thanks, everyone. I'm excited to be here. I know we want to have some time for questions at the end. So I have some slides, but I'm going to try and go through them pretty quickly and just give you a little bit of a highlight of what I'm working on. Let's go ahead and share the screen, because I want to give everyone an opportunity to ask questions. We've learned about some really amazing clinical and research work. And so I just want to start by saying that although I am in the Department of Neurosurgery and Physiology, I'm not a clinician. My focus is entirely on research, and I'm going to tell you just a little bit about some of the work that I am doing on how we can use neurotechnology to kind of boost our brain to help us both learn and recover from injury. And so I'm going to start by, asking the question, can we tap directly into the nervous system to help our nervous system and our body heal itself after injury? And what I want to tell you about today is how our peripheral nervous system, which is the nervous system that runs in our body, connects to our central nervous system, which is our brain and spinal cord, and how that connection, that communication between the periphery, the central nervous system, can be used potentially to help us treat a variety of injuries. So when we electrically stimulate our peripheral nerves, that drives activity in our central nervous system. And one of the main ways that this has been accessed for treating patients is through electrical stimulation of the vagus nerve. Now, the vagus nerve is the biggest nerve in the body. It is, so to speak, an information superhighway between the brain and all of the internal organs of the body. It controls the parasympathetic response. So the vagus nerve is responsible for what's known as your rest and digest system. It slows your heart rate, it slows your breathing, and speeds up your digestion. But also it serves another really important role of sending information about our body state back to our brain so that our brain can make decisions about that information. So currently, it's possible to electrically stimulate the vagus nerve, and this is used to treat epilepsy and reduce seizure frequency in patients with epilepsy. It's used to treat depression. And most recently, it's been explored and is now available to drive motor rehabilitation after stroke. So let me tell you a little bit about that technology. Here I'm describing how vagus nerve stimulation can be used to restore movement after a stroke. And these are in patients who have experienced a stroke and have upper limb, upper arm mobility impairment. An electrical stimulation device is implanted on the vagus nerve in the region of the neck, sort of where it's bundled together, sending all the information to the brain. When the vagus nerve is stimulated, it can interact with different regions of the brain. And in this context, vagus stimulation is paired with a movement. And the patients who receive this paired electrical stimulation of the vagus nerve every time they engage in a movement and physical rehabilitation, they can achieve more functional recovery, more movement recovery than patients who are just engaged in physical rehabilitation alone. This basic paradigm of pairing vagus nerve stimulation with a behavior is actually being explored to treat a wide range of disorders, including spinal cord injury, traumatic brain injury, multiple sclerosis, addiction, PTSD, and even peripheral nerve injury. So there's the possibility that by tapping into the way that your peripheral nervous system and your central nervous system communicate, it might be able to drive plasticity in ways that can span across a number of different types of disorders. So in the next 2 minutes, I'm just going to tell you a little bit about my lab's research. And we've been focusing specifically using animal models to see if we can use vagus nerve stimulation to help recover movement in a model of multiple sclerosis. So first I'll introduce the key members of our lab, and these are the mice that we use in our experiments. Here you're looking at a mouse reaching for a food pellet through a slit. We can train the animals to perform this behavior, and then we can create a model of multiple sclerosis. So let me tell you a little bit about multiple sclerosis. In MS is a disease where myelin, which is an insulating factor in the brain, is lost. And so neurons can't communicate together as effectively. There are some stem cells that can make new myelin, but the repair process in patients with MS and in animal models is typically incomplete. So oftentimes, animals and patients are left with permanent motor impairment. And so we're exploring if new therapies like vagus nerve stimulation can be used to promote additional repair in this system. To do this, we actually are able to image directly into the brain of mice. And so here I'm showing you a picture. You're looking down into the brain of a mouse. What you're looking at are individual cells that myelinate axons. So these are called oligodendrocytes. They're the cells that die in MS. We then give the mouse a drug that kills these oligodendrocytes. Sorry, we give the mouse a drug that kills these oligodendrocytes, and then we can watch them recover. So here's a video over time. There you see some of the oligodendrocytes die, and then over time, new oligodendrocytes are formed. And so what I'm showing you here is after injury, this is the amount of recovery of oligodendrocytes. In gray is what happens in animals that are just given the drug and allowed to recover naturally, and they get about 50% recovery. Animals that are engaged in a physical rehabilitation task get about 60% recovery. But when we add VNS into the mix, we can increase that percent recovery nearly to 90, 95%. And so with that, I think I will go ahead and conclude. So we have time for questions. But I just want to say that it's possible to do this in patients, either with an implanted vagus nerve stimulator or even maybe with a non-invasive stimulator. And so we're exploring some ways that we could stimulate the vagal afferents in the ear to maybe promote this learning program in patients with multiple sclerosis. So thank the lab, and I will stop sharing to allow some time for questions.
Great. Thank you, Cristin. Tammy, I'm going to turn it over to you.
Well, as usual, we have a lot of questions and not very much time. So we'll get to as many of them as we can. And I want to remind everybody also, email me if you want to come to the graduation breakfast, please. Okay. I'll start with this one. To any of you, what could cause a temporary freeze in the ability to speak?
Yeah, I can answer that. For people with Parkinson's in particular, that's a not uncommon problem. We talk about freezing often in the context of gait or walking, but the underlying problem or circuitry is probably similar in the sense that an automatic or subconscious behavior like walking loses its rhythmicity or automaticity in Parkinson's disease due to probably some complex interaction of a variety of different brain structures. And so you can see that freezing phenomenon in people's walking, but you can also see it in other movements. You can find it in their thinking oftentimes, and you can find it in their speaking as well. So it's the same underlying problem where those basal ganglia structures that are responsible for selecting and refining movements lose their ability to do so accurately and smoothly, and that can show up in a variety of places, commonly gait, but in speaking or thinking as well.
Okay. With regards to Parkinson's, there has been very little progress apparently since the development of L-DOPA in the 1960s. So do you see any systemic issues that might be slowing the development of new treatments?
Yeah, I can answer that
Take
again.
that one. Okay.
Yeah, a complicated question. I think you're probably referring to the main limiting issue that we've run into, which is that we really don't have a good disease-modifying or disease-slowing treatment for Parkinson's disease, which highlights that it's a complex and multifactorial disease that we don't completely understand in terms of how or why it starts, how and why it progresses, and how that might be able to be stopped. I talked about some of the pathological changes that we know, but it's certainly not as simple as, for example, clearing out or removing some of that synuclein, although that's a promising avenue for treatment. I think a good analogy is Alzheimer's disease, where for many years there were no significant disease-modifying treatments, but just in the last couple of years, we've seen 2 medications now come out that do have a disease-slowing effect for Alzheimer's by doing something similar, which is removing the pathologic protein or amyloid from the brains of those patients. Although there were many trials up for the last several decades that tried to do the same thing or something similar and were unsuccessful in showing any disease slowing or disease arrest. So, you know, these are complex disorders that we don't completely understand, both in terms of how they originate and how they propagate. which has been one limiting factor in developing a disease-modifying or disease-slowing treatment.
These different neural engineering devices, how many of these treatments are available to the general public? And do they have to have some kind of special kind of insurance?
I can take that. There are a lot of neuromodulation devices and more that keep coming out. It's a long, slow process to get through and get fully approved, that in the sense that insurance would cover it, and that it's first FDA approval and then insurance would cover it, and you sort of need both of those things. We also frequently will use the same devices, as I was sort of mentioning, for different new indications. So we do deep brain stimulation with the exact same devices in the exact same way, but just targeted in different regions for different diseases. Some of the ones, for instance, that Dr. Welle was mentioning with vagal nerve stimulation, that's been around for epilepsy for a long time, and then that can be applied to newer diseases, as it has for, say, depression. And then there are, newer things, some of the ones that I was mentioning for, say, brain-computer interface, that those are still not FDA approved. So all of the research is done under FDA governance in a method called an investigational device exemption, which is essentially sort of this device is, perhaps shows promise, but is not approved yet. And so we need to gather the data to be approved, which definitely Dr. Welle can speak more on, since she was at the FDA doing that process for some period of time.
But it's safe to say that everything you saw with the movement of the man with the arm and that sort of stuff, that's all experimental, all non-available.
Yes, very much so.
Yeah.
This one's for Cristin. Is VNS always implanted, or is there a way to stimulate your vagus nerve externally?
Yeah, I'm really glad that someone asked that question. Vagus nerve stimulation can be either implanted or applied in a non-invasive way. And so for the treatment of epilepsy, depression, and motor rehabilitation from stroke, those technologies are implanted, and it's an implantation right on the vagus nerve here in the neck. There is a way to electrically stimulate vagus nerves that are in the ear, and you can do that non-invasively. So it's just something that can be applied to the surface of the ear, and that is actually FDA approved, available for medical use for the treatment of opioid use withdrawal. And there are a number of other new disorders that are being investigated, including our group, which is starting to look at non-invasive ear-based vagus nerve stimulation for motor recovery in multiple sclerosis.
Wow. Okay, last question for tonight, but remember, we'll try to answer everything and send you the answers, but this is kind of I think, an interesting one. What was so unusual with Michael Fox's treatment for Parkinson's? Did he have DBS, and if so, did it work?
Yeah, he's been somewhat coy about some of the treatments he's had for Parkinson's, including DBS, which to my knowledge he has not had. His Parkinson's case is very unusual, particularly with how young his Parkinson's symptoms started in his 20s, which is very unusual, although not necessarily impossible. And so any disease on that sort of time scale, when it usually starts in someone's 60s, makes the whole nature of the disease a bit different. And so looking at someone who's in his 60s currently, but has well over 30 years of Parkinson's, means that he may not show a lot of the usual symptoms, or may not kind of progress in a manner that you would see most people do. So it's certainly an unusual case, even though he is the standard bearer and a great advocate for Parkinson's disease. He's maybe not the typical Parkinson's patient that you would otherwise see.
Thank you.
Okay, I think thank all of our speakers tonight. I think that was terrific, and And the next week, we will be doing an introduction to psychiatry and substance abuse. It'll be the last of our 6 sessions. So we welcome everybody back next Tuesday, 7 o'clock. And again, thank you, our speakers, for tonight.
And let me know if you want to come to the breakfast. Thank you.
All right. Good night.
Have a good night.